that the breast-conserving surgery may provide better survival to the patients. So let's go back to our main topic. So what about multicentric and multifocal tumors? So there's, up to this time, there are only few retrospective and some prospective small sample size studies. But in this meta-analysis, including 10 of those studies, they compared the patients in two levels. First, they divided the patients, those patients who received breast-conserving surgery, divided into two, that in one group, the tumor was unicentric, in the other group, it was multifocal or multicentric. And in the second analysis, they only put those patients who had multifocal and multicentric tumor, and they stratified these patients for comparison in two levels. One, the patient received breast-conserving surgery, and the second, the patient received mastectomy. Again, reminding you that these are not randomized studies. These are retrospective, non-randomized, observational prospective studies. So in the first analysis, those patients who received breast-conserving surgery, they found that those patients who had a multifocal, multicentric tumor had 2.5 times more likely to have recurrence, a local recurrence, compared to those who had unifocal tumors. So therefore, if you're operating a patient with a multifocal tumor with breast-conserving surgery, if this patient had to be a unifocal tumor, you would have a less recurrence compared to the multifocal tumors. But when we go to the second analysis, when they compared only putting those patients with multicentric and multifocal tumors, they divided these patients into two, as I told you before. One, they made a conserving surgery, and the second, they made a mastectomy, and they found similar local recurrence rate. So if you have a patient at the baseline, a multifocal, multicentric tumor, if you would opt to do a mastectomy, it doesn't give you an extra advantage over doing a breast-conserving surgery. But again, these are retrospective or observational prospective, but small-sized, non-randomized studies. And again, in another meta-analysis showed that these studies have moderate quality, they're historical, underpowered, with limited follow-up. Again, this is very important, and biased. So they concluded that we need a robust evidence to say that breast-conserving surgery is safe in these patients, especially in the multicentric patients with the multicentric tumor. So far, two studies started, one from the United States, from North America, the other one from the UK, but unfortunately, the second one, the Miami trial, didn't have too much patient accrual, so they stopped this trial for the beginning, because they started with a preliminary pilot study to understand whether they can randomize patients in this trial, and they started in 2018, but they couldn't finish it up. So the only study that we have so far is the ACAZOC Z11-102 trial. And recently, maybe you may recall, in San Antonio meeting this year, they presented their results. So I will be concentrating on that trial more. But before that, again, I would like to remind you that this study is a one-arm study. There is no comparison arm. So only the patients who received breast-conserving surgery were followed, and the results were given upon. And at the beginning of this trial, this study, they set an acceptable local recurrence rate, which is 8%. So that means that if the recurrence rate is found to be less than 8%, this is acceptable, they said. So before they reported their result this year, in 2018, they give a preliminary report on the figures that they have, that they recruited so far. So from this paper, we understood that the patients mostly had two lumpectomies. That means, this is very interesting, because this is not one lumpectomy including two tumors. They did 2 or 3 lumpectomies in 3 different sites, and then they included these patients into this observational arm. So 30% of them only had single lumpectomy, including 2 tumors inside. So at the beginning, they aimed to do a breast-conserving surgery, but they failed to do this, so they converted to mastectomy in 7% of the patients. So at the end, only 93% of those patients had a breast-conserving surgery. But in the first intention, that means in the first operation, they could only do this in 68% of the patients. That means that they need to do a second, a third, a fourth, and a fifth operation to achieve a negative margin in 20 to 25% of the patients. So they needed to do recurrence operations to achieve negative margin. And for the closure, because this is also important, in 85% of the patients, they did a simple closure. Either it's a 1 lumpectomy, or 2 lumpectomies, or 3 lumpectomies. Only 14% of the patients, they need to do an oncoplasty type rearrangements, or in 1.5% of the time, a breast reduction therapeutic mammoplasty. So they did a fairly simple thing in this trial. And as a result, this year they reported their result in San Antonio back in December, early December, and the 78 centers entered their patients, so they started with 270 patients, but 66 are excluded. At the end, they only had 204 patients for the primary endpoint analysis. And as you can see on the left side in the table, most of these patients are elderly. So they aim to include those patients who are over 50, but the mean age of these patients are 60. And the number of lesions, because these are multifocal, multicentric tumors, 97% of them only had 2 tumors. Only 3% or 4% had 3 tumors. And then mostly they are T1 tumors, in 60%, as you can see. And again, mostly they are hormone-positive tumors. 84% of them were luminal type, had luminal type of tumor. And 78% of the patients had N0 status for the axilla. So for the margins, all patients had a negative margin, and 85% of them had a margin 2 millimeters or over. Only 14 or 15% of them had margins less than 2 millimeters, but negative margin. So the result is, because please remember that in the beginning, the actual set for the recurrence rate for success was 8%. So at the end of 5 years of local follow-up, they had 3% of recurrence, in breast recurrence. And when you look at the other factors, the confounding factors, which might have an effect on recurrence, which is number of the diseases, and I mean the foci, like 2 or 3, the Afron T category, the tumor size, N status, the margin, and tumor histology, there were no difference. So whether they have an N1 or N0 or T2 or T1, or the margin is less than 2 or more than 2, there's no difference by means of local recurrence in these patients. When we go to the other analysis, considering the subtype of the tumor, here there is a difference, but this is not statistically analyzed, but you can see from the table that the hormone positive, which constituted the majority of this cohort, at 2.5% of local recurrence, where in triple negatives, you had a 10% of local recurrence. So this might just a bit challenging for you because there is no statistic analysis. But again, let me remind you that even you're doing a breast conserving surgery for unifocal tumor, we see the same recurrence rate difference between the hormone positive tumors, which are luminal tumors, and the triple negatives. And here in HER2 positive ones, because they have very few patients and they have no recurrence rate, recurrence case in this cohort of 23 patients with HER2 positive tumors. So again, another analysis, they made a stratification, those patients who received an MRI before operation, and those who didn't have an MRI in the operation. And there was a big difference. If they would have done an MRI, so they had a 2% of recurrence, but if they didn't do an MRI, so they have a 23% of recurrence. So MRI has an impact on finding extra foci in the breast. So it is paramount here, it seems paramount here to have an MRI before the operation. Another analysis, those patients who had hormone-positive tumors, if the patient received hormonal treatment with tamoxifen, with an AI inhibitor or tamoxifen, the patient had a 2% of recurrence, where if the patient, although she has a hormone-positive tumor, but didn't receive anti-estrogen treatment, the patients had a 20% of recurrence. So this is also a significant finding from this trial. But before this finding, because we always think about from the surgical perspective, but think from a radiotherapy perspective, because this has a significant impact on the quality of life of those patients, because not only the breast, the whole breast is receiving radiotherapy, also the boost is giving to each lumpectomy site. That means if you do 2 lumpectomies or 3 lumpectomies, you have to give 2 or 3 boost treatments into the breast. So does this have an effect on the quality of life and the appearance of the breast and overall the cosmesis? So this study from 2022, again a very recent study, just extrapolated some data from this trial and told us that radiotherapy with the boost were well tolerated. Only 3% of the patients had a dermatitis grade 3 or more. And absolute boost volume, if it is increased, the absolute boost volume, then you have the chance to see more dermatitis, more serious dermatitis in these patients. But the relative boost volume is not related with the dermatitis. And the third study, from just before reporting the final result, it was reported in 2020 on the cosmetic outcome, because this is totally related with the surgery you've done, and also it's related to the radiotherapy you've given. So in this trial, again, in this study, they found that they looked for the quality of life from the perspective of the patient-reported cosmesis and the breast Q scores, and they found that the cosmesis at the end, in the majority of the patients, it resulted with a good or excellent outcome. And there's no significant difference when you stratify the patients according to the age, the number of lesions, 2 or 3, number of lumpectomies, whether it is 1 incision or 2 incision, or you did an therapeutic mammoplasty, and the size of the largest area of the disease. And again, going back to the previous study, they found that neither the absolute nor relative boost volumes were appeared to significantly influence the overall cosmesis. The absolute boost volume is increased because we know that from the previous study that it causes more dermatitis, more serious dermatitis. So it has an effect on the outcome in the cosmesis. So the breast Q scores are eventually, in this group of patients, it's found to be low. So this was all from the Z11102 study, but I would like to give you the results of one more study. This is from Milan group. It was published again recently, and this is a retrospective analysis. It's a matched cohort analysis. They made 2 groups. One group received therapeutic mammoplasty, oncoplastic mammoplasty with 1 incision, and the other group, they had the mastectomy. And the groups were balanced according to the tumor size, histology, nodal status, grade, and subtype. So at the end of 8 years of follow-up, they found similar local, regional, distant disease relapse rates, disease-free survival, and overall survival. But when you look at the table more deeply, of course, they said they found, because they reported a similar overall and disease-free survival, which is almost the same in all randomized studies before we had for breast-conserving surgery. But here, the 10-year cumulative local recurrence, although it's statistically not different, but after oncoplastic surgery, it is 8% compared to 2% in the mastectomy group. And within the first 5 years, the groups were similar. The all difference became apparent after 5 years. So maybe we should wait a little bit more to see more, robust data on these, on this type of surgery on multifocal and multicentric tumors. Again, this is a retrospective, a matched cohort analysis, not a prospective randomized study. So far, we don't have a randomized study. That's unfortunate for us. So finally, this is a survey that we made last year to many surgeons all around the world, and we asked them, well, if you have a patient with a multifocal and multicentric tumor on triple assessment, what would your surgical approach? Would you do a breast conserving surgery? And nearly 45% of the surgeons said that they may consider breast conserving surgery if technically feasible in these patients. In addition to this, 25% of the surgeons said that they may consider if only the tumor is multifocal but not multicentric. So from this, we might understand that nearly half of the surgeons would prefer doing breast conserving surgery if technically feasible under one incision maybe, because they might consider that not under two incisions, but they think that this would be a rational approach to these patients. But of course, we have many gray areas here. So we only have one prospective, relatively good design study, but is it, because the margin issue is still there, because most of the patients had more than 2 millimeters of margin. So should it be a safe margin for these patients as well? So we need more data on this. More data with the patients who are having a no-income tumor. And also, for each subtype, we should analyze data separately. As I showed you, the recurrence rates after triple negative tumors are higher than those who had a luminal type of tumor. And also, is it safe, because all of those patients that I showed you, most of them are, the median age is 60. That means more of the patients are having an age more than 50 years. So is it safe in hereditary, multicentric, or young cancer patients? We don't know the answer to this. And also, can we apply the same approach to those after neoadjuvant systemic treatment? Because these are all different scenarios that we have to consider. So, and we can't have any answer from those trials that I showed you so far. So they're not robust so far. So the conclusion. Similar local relapse rate after breast conserving surgery compared to mastectomy. Yes, we saw it from these limited evidence. And breast conserving surgery seems a reasonable alternative to mastectomy. But I cannot say that this for all the patients. So the data from the previous studies didn't have an externally validated proof so far, because they only have a specific subgroup like an elderly patient with the luminal A or B tumors with the margins more than 2 millimeters. But what I can tell you as a robust evidence is radiotherapy after multiple lumpectomies seems to be safe. And patient satisfaction is also found to be high after multiple lumpectomies. So if there is no problem with the oncological control, so on the cosmetic side, and it seems a feasible option. And the therapeutic mammoplasty techniques may provide better cosmetic outcome and less radiotherapy-related complications, because it will only have one incision and one boost will be considered in these patients. So, thank you very much for your kind interest in listening to me.
Thank you very much, Dr. Bahadir. You posed a very important issue that needs a lot